Good afternoon, good afternoon, good afternoon, and welcome everyone. Welcome, welcome, welcome. If you can hear me, just raise your hands or open your mic and say hello. Are you able to hear me?
Hi, Cheryl. Good evening.
Wonderful. So you're hearing me. All
Yes.
right. Thank you. Thank you. I see the hands. I heard the welcome. Thank you so much for joining us this afternoon. Welcome to the very first session in our Omega Kappa Infection Prevention and Control and Non-Nursing webinar series number 3. We are off to a great start and we're going to just get you involved and challenge your brains for 2 seconds. So while I'm talking, everybody gets a quick piece of paper. All right. Let me start off by saying we thank you so much and we're going to remind you that we are in a professional setting. We have asked the persons who are joining us to do so with their full names as they registered. As you registered, please ensure you've changed your name. Anybody who's in here with a partial name, a first name only or a surname only with an iPhone or a Samsung on it, you're going to be put back into the waiting room. Anybody who is in here who did not register for our session and somebody shared their Zoom thing with you, you are also going to be put out of the meeting. We ask persons when you come in, the setting automatically mutes you. Please keep your microphones muted unless you are acknowledged when we get to the question and answer session. If any of your friends or colleagues are joining us and they haven't heard what we are saying, then I encourage you to tell them because it will mean they may be in the waiting room. If you have chosen to join us on YouTube, and we welcome you to our channel, we ask you to subscribe. We have lots of information already there, but we ask you, type your name in the chat over on YouTube because unlike Zoom, where you're going to enter with your full names, we may not know you're there over on YouTube unless you type your name in the chat. So we just want to thank you for joining us. We're going to be off to a great start. And those are the reminders again, because we're going to start putting people back out in the waiting area as soon as we are finished with this segment. All right. So today we have a wonderful presenter. I won't tell you the topic because that's the moderator's role. But our moderator today is none other than our chapter member, Miss Camille Abdul Karim, and she's going to be taking us through a few things and giving you the official welcome. But before she comes on, you see she waving to you already, pretty in pink. We are going to do the little challenge that I said I had for you. All right? So who is ready? Everybody got their paper? Let me hear if you got your paper. Or your phones. You know, we have notepads
Yes,
on
we're
phones
ready.
and tablets these days. Everybody's ready? So listen quickly. It's a 45-second challenge. So you have to be quick, you know. And then there's a prize because you will have to post your answers in the chat. And when I say answers, I don't necessarily mean that you're going to type out the things, right? Everybody's ready with their paper now? All right, so I'm going to share my screen and you'll be able to see what I'm talking about, but no cheating. So I want you to get the rules really clear. A slide is going to come up. It will have some information on it. You're going to have to unscramble the words, right? And it's 8 words in total. You will have 45 seconds. When I say stop, I'm going to remove the slide. Then you are going to type in the chat how many words you were able to unscramble. So if you only unscramble 2 or 3 or 4, put those numbers. The person with the highest number, we're going to ask you to send us a picture of what you unscrambled. We do evidence-based practice. We're nurses, right? And so we're going to see the evidence so we can determine who is the winner. So let me say that one more time. Have your phone with your notepad or your computer or your piece of paper. We can go old-fashioned. Paper and pen works. Slide is going to come up, 8 words to unscramble, and then you're going to get 45 seconds. And when those 45 seconds are done, the slide will be moved. Type in the chat 3 words, 4 words, 5 words, 6 words. The person who has the most, we're going to ask you to send us a picture so we can verify the evidence for the prize. When you've done typing in the chat, I'm handing right over to Miss Abdul Karim so that we can start our session. Who is ready to unscramble? Everybody brains working? Let me hear who is ready. Anybody? Who's out there?
Yes, I'm
Ready?
ready.
Wonderful.
Ready.
All right, let's go. 45 seconds. We'll start right now. Go. Ten seconds to go. 2, 1. Wonderful. Slide disappears. All right. Timer says it's up. So now I'm going to be looking out for you in the chat. How many words did you unscramble? And then look out for us to contact you to send the evidence. I see the answers start coming in already. Wonderful. Right over to you, Madam Camille.
Thank you so much, Cheryl. Boy, I won't even bother to tell you. I need that monkey emoji that goes like this. My unscramble, I see some wonderful unscrambles there. But I'm your host for this evening. I would just like to welcome you to this, our first session in the third series of Omega Kappa's Infection Prevention and Control series. It's a non-nursing webinar. That's one important thing for you to note. I also want you to tag a friend. It's not too late to share. Tell them to hop onto YouTube. Tell them to log on. We are waiting for them to come on. We have wonderful information to share with you. And so we would like for you to absolutely share. I see that we have 36 of us on Zoom this afternoon. I'm not sure how many persons are on YouTube, but I would just like to extend a warm welcome to you. And I want to congratulate my chapter. I'm so proud of Omega Kappa on continuing in providing this kind of a resource for our members in providing these infection control series. All right, so this afternoon, we have a very dynamic speaker. Some of you may know him, some of you may not. Our speaker this afternoon, I'll tell you who it is. Or maybe I should do a poll too, Cheryl. I should probably let them guess. I'll talk about the person. This person is a former chaplain at the Jamaica College, a true blue gentleman. He is a graduate of the Latin America School of Medicine. He graduated with first-class honors. He then went on to do a master's in public health, which he successfully completed with distinction. He is a surgeon, a physician. He lectures at the UWI School of Nursing. Who can tell me who it is? Let me see those responses in the chat and on YouTube. Quickly. It is none other than Dr. Jermaine White, my friend, my colleague, my teacher. It is such an honor to introduce you this evening. He will be speaking to us about emerging and re-emerging diseases. We see a myriad of things happening throughout the last 2 years. And we know that he will give us a keen definition of what emerging and re-emerging diseases are. It is up to us as healthcare providers to keep in our ammunition updated with current evidence, current information, so that we can have a hold on what's going on in the world of microbes that seem to be a never-ending struggle with mankind. Without further ado, I turn over to Dr. Jermaine White. Just before I do, I'd like to give you a few instructions. We will have a question and answer segment, which will be the last few minutes of the program. If it is that you have a question, please feel free to type it right there in the chat. We will acknowledge you at the appropriate time. Also on YouTube, we do have someone monitoring the chat there, so you can go right ahead and write your questions out. If you have a question and you would like to say something, raise your hand and please wait to be acknowledged. We just implore you to enjoy this afternoon's presentation, and thank you for joining us. Over to you, Dr. White.
Okay, thank you. Thank you so much, Camille. Thank you, Cheryl. Thank you, Omega Kappa, for having me yet another year. It has been a pleasure. I presented last year, and I am really elated that you guys invited me to present again this year. And so I want to say, express my gratitude, of course. And without further ado, we will get right into it. Also, I want to acknowledge those who have taken the time to be a part of our presentation today. If you see me looking towards this side of the screen, I have a second monitor there that I'm going to be presenting from. So in order for it not to be distracting, I will turn my video off because it looks a little distracting just looking away from the screen. So I'll be presenting from here. All right, so this time around, my presentation will be on emerging and re-emerging diseases. And just by a way of confirmation, can I just hear in the chat whether you're hearing me loud and clear? Do I need to adjust my audio? Are you also seeing my screen before I get into anything? Do I need to, are you hearing me? Yes, no? Maybe
we can
so?
hear you clearly, Jermaine, and I am able to see your screen.
Okay, excellent, excellent. So before we begin, thank you, Camille, for such an excellent introduction. Unfortunately, I wasn't a chaplain at JC. I was a school captain. But I mean, if you're declaring it over my life, I receive it in the name of Jesus. So we're going to be looking at emerging and re-emerging infectious diseases particularly. And I want to say beforehand that I do not have any disclaimers right currently. And so I really appreciate the opportunity to present on this topic because it is a part of the global public health focus at this point in time. And so we will get right into it. So essentially, we're going to be looking at the terminologies. I'm going to do the presentation a little bit different today. Of course, as a matter of outline, we're going to be looking at terminologies, classifications, focusing on certain conditions and how we can prevent them. But I wanted to go back to basics for any of you who may have had any experience with me as a lecturer, as a teacher, whether on the hospital, as a nursing student, or at the University of the West Indies. You would know that I am a man of principle in the sense that I really love when we understand the basics and the fundamentals. And also with a public health background, it's very important for us to understand all of this. Last year, we looked at things like genetic mutation of bacteria and multi-drug resistant organisms and whatnot. But we're gonna go back to basics a little bit. We're looking at what is a disease. So a disease is generally constituted as a condition that impairs normal tissue function. Essentially, it interrupts homeostasis. But it is most extensively defined by the WHO, with the last updated definition in 2018, 2019, where it is known as a complete state of well-being. And this well-being has to do with the physical, emotional, psychological, environmental, social, your economical, as well as your spiritual well-being. And so health can be defined not just from a biological perspective, but a biopsychosocial perspective. But in the sense, or in the case of what we term as infectious diseases, right, we're mostly going to be focusing on the biological aspect. However, there are instances where we will see where the other aspects play an important role in seeing. Now, disease can either be from a genetic origin, which means that you have your ribonucleic building blocks or deoxyribonucleic building blocks that have genetically programmed your cells to have an impaired function. And we see this in, for example, sickle cell disease, where you have that conversion or the mutation from I think it's glutamine to valine, right? In the beta-6 loci of your hemoglobin, right? And so you have that conversion and you have a deficit. So another example is cystic fibrosis. You have diseases that are also associated with aging. And I may point out that here, your disease of aging doesn't necessarily mean that you have to be in the geriatric age, because autopsies done on patients in the neonatal period, they have seen things like atherosclerosis, but we know that these build up, your deposits within the vessels actually happen as we age. And of course, we have infectious diseases. Now, infectious diseases are usually caused by the invasion of a host by agents whose activities harm the host cells. And so this is going to be primarily our focus today when we're looking at the diseases. Now, another definition I want to bring to your attention is the definition of a pathogen. And a pathogen, a lot of times when we think infections, we almost automatically go to bacterial infections and viral infections, but there are lots of other organisms in existence that can cause an infection. These are called pathogens. They're essentially microorganisms that are capable of causing disease, and we know what disease is, impairing your normal tissue cell function. Now, there are also a different type of pathogens which are called opportunistic pathogens, which are essential these are classified as potentially infectious agents that rarely cause disease in individuals with a healthy immune system, but in persons whose immune systems may not be healthy, they do cause diseases, right? So these are just a type of pathogens that usually would not affect an otherwise healthy person. Now, in terms of your balance between infection and disease, they are not synonymous. And what do I mean by that? Your infection and disease are not synonymous, because an infection results when the pathogen invades and begins growing in the host, but they don't necessarily demonstrate any form of disease. And to understand this a little clearer, we actually take a look at what we call the natural history of disease, or the disease process. Now, there are certain things that are called your disease reservoir, and the reservoir for a disease is a site where the infectious agent survives. For example, humans are the reservoir for the measles virus because it does not infect other organisms. And animals often serve as a reservoir for diseases that infect humans. And we see that very evidently in cases of Ebola, in cases of even the emerging COVID-19 disease that we saw, where the initial cases, the ground zero of the cases actually came from contaminated disease reservoir or animal sources, which were disease reservoirs, right? So to understand a little better what we mean by infection versus disease, so let me just get my pointer here. Right, so we have essentially an invasion, right? An invasion, so we have a susceptible host, right? And you have an invasion of a microorganism, virus, bacteria, fungi, protozoa, whatever it is. So you have that invasion and it begins to multiply, begins to infect the cells, invade them, multiply, it begins to grow rapidly within the organism. But then once it has reached a specific number of multiplications, or it has actually caused a significant type of damage within the organism, right, you actually develop signs and symptoms. And so once the signs and symptoms develop, this is where you are known to have a disease, right? So infection can occur, but there's no evidence of disease. And then you can have disease process. And then the disease process will continue where you are either cared for, that you have a diagnosis and treatment, and have an outcome which can be a resolution of disease, or you can result in death, right? Usually, once you understand the natural history of disease, you'll understand at which level you can operate in order to prevent certain conditions. So different types of prevention based on the natural history of disease. So your primordial and primary prevention will actually take place in patients who are usually susceptible hosts who have not had the invasion of the pathogen as yet. Your secondary prevention would employ methods or tools that are required to detect early. And there is a point here that's where it says detection is possible, where we call the critical point of a disease. And the critical point of a disease is the point at which one can detect it before it causes signs and symptoms. And this disease can be cured, or an intervention can occur that can prevent the disease from progressing. And we see this a lot in like our pap smears, for example, where our pap smears are actually a type of secondary prevention, because the thought is that you are trying to find persons who are at risk, who have already had changes of invasive HPV, or I should say pathological HPV, right? And we try to detect these changes before they actually develop into cervical cancer, where the detection is possible. But once cervical cancer exists, right, the disease will be there, and that's a different story. So anyways, the natural history of disease will help us to understand the difference between an infection. So an infected host doesn't necessarily have to have the disease until they start showing signs and symptoms. A similar pattern is seen in HIV, where the patient can be HIV positive, basically because of the invasion of the HIV virus. And the signs and symptoms, like your stage 3, stage 2 disease, actually does not occur until you start showing symptoms. Now, in terms of the terms contagious versus virulent, and these are just some terms, as I said, some basic terms that we're going to go through. Your contagious versus virulent, some infectious agents are easily transmitted, which means that they're very contagious. So your level of contagion is actually determined by your ease of transmissibility of the organism, but they are not likely to cause disease. So they are not very virulent. So the virulence of an organism is the ability of that organism to actually cause serious disease, while the contagiousness of the infection has to do with how easily it is spread, right? So using an example of even our present day situation with COVID-19, as the strains progress in their mutation, they tend to be more contagious, but less virulent, right? And so we saw where the Delta was a very virulent form, right? The Omicron, which was a further mutation away from the Alpha strain, was more contagious, but less virulent, because the virus, as we'll see further on in our presentation, the viral particles cannot exist without a human host. And so essentially, if you are killing off all the human hosts, then the virus will have nowhere to replicate and to survive. And so when it mutates, it becomes easier to transmit, but it kills a lot less. And so you realize that as certain diseases mutate, they are more contagious, easily caught, but they are less virulent, right? And so the example that is here as well is the whole polio, which is very, very very contagious, but only 5 to 10% actually develop the disease. Now, other infectious agents are very virulent, but not terribly contagious. And we see this especially in the Ebola hemorrhagic fever, where a virulence of the virus is about 50 to 90% fatality. So this is the case fatality rate, which is the number of persons, case fatality rate is the number of persons who will actually die after being infected. So 5 to 9 in 10 persons who develop Ebola usually die, but it is not as contagious as it is said to be. However, there is something that I must point out, that there are diseases that are not necessarily very contagious, but there is an arithmetic rule in public health that has to do with disease transmissibility. And so and so if you are frequently in contact with a disease source, the pathological load or pathogen load of the organism is very high. So for example, somebody with HIV, let's use that example, the person is having sexual contact with an HIV positive person with a viral load greater than 100,000, right? Once we know that the viral load is greater than 100,000 or very high, right? The probability of transmitting that infection is going to be higher. The more contact that person has, the longer the contact, so the more frequent, the longer the contact, and the viral or the pathogen load of that virus or organism, tends to increase your rate of transmissibility. So the Ebola virus, even though it is not on paper deemed to be very, very contagious, because of high housing index, so persons are having a lot of persons living in their home, in their homes especially, there is that possibility of it being transmitted quite easily. Now, how do infections happen, right? Essentially, in order to cause disease, the pathogen must be able to enter the host body and to adhere to specific host cells and invade and colonize these host cells. So there must be some invasion at some point in time. And that invasion will include some adherence to some particular cell or tissue within the body, and that will be invaded and colonized. And after it is colonized, it will replicate and destroy the tissue. And so remember the definition of disease going back. Disease is actually the invasion, is when the invasion of a pathogen causes a disturbance or a disruption in the normal function of a tissue. Hence, it will be called a disease tissue. And so this is how infections happen. And primarily, for example, the HIV, if you remember the pathophysiology of HIV, and I'm using this example a lot because we'll see that it's a very important disease with respect to emerging and re-emerging diseases in our current epidemiological space. So with HIV first infects the host either through whatever route of transmission or mode of transmission, with his mother to child, infected intradermal intradermal or IV needle use, your infected blood transfusions, your sexual intercourse, that sort of thing, right? So you have invasion, then you have adherence to the CD4 cells, the CD4 receptors on the CD4 cells, and then you have injection, where or invasion or infusion, where the viral particles enter the host cell. Then of course you have your reverse transcriptase and your integrase action. So you have your reverse transcription and integration and all of these things that are going to happen. And then it results in daughter cells of the virus being replicated within the cell, and that causes damage or destruction of the CD4 cells. Hence the CD4 count in an HIV patient will go very low as the viral load increases. Now, pathogens usually enter through natural orifice or through breaks in the natural skin barriers, such as wounds, cuts, abrasions, whatever you want to call them. And so again, the natural history of disease, we can see where this results in the biological onset. And then of course, you have the replication and the reproduction, and this leads to this tissue destruction, which then causes signs and symptoms to appear. And then the disease process, as we know it, begins. So you have infection, disease process is either detected, treated, diagnosed, whatever it is, and then we have the outcome. Now, to the meat of the matter, having gotten all that basic information out of the way, we are now going to look at what we call emerging and re-emerging infectious diseases. And so emerging infectious diseases, according to the National Institute of Allergy and Infectious Disease, the NIAID, an emerging infectious disease is usually commonly defined as one of three things. It usually is an outbreak of outbreaks of previously unknown diseases, right? So the COVID-19 disease was considered an emerging disease because, and so even HIV in the 1980s, right, 1981, when it was officially declared on scene, right, was considered an emerging disease, right? In 1852, when you had the cholera epidemic, before it became a pandemic with John Snow, cholera was an emerging disease. So it's the outbreaks of previously unknown diseases. And it can also be a known disease that are rapidly increasing in incidence or geographical range in the last 2 decades. And so we know that HIV was an emerging disease from the 1980s, but it still remains an emerging disease because we haven't quite gotten that pandemic under control. And we have, and it has been increasing despite the number of public health implementation and programs that we have done so far. There have been instances where the numbers have decreased, yes, but there has been a steady increase or maintenance of that number. throughout the last 2 decades. And so we have persistence of infectious diseases that cannot be controlled, right? And of course, truthfully, in the 1980s, HIV did this. Today, HIV is doing this. And today, HIV is doing the third one as well. So emerging diseases are usually new diseases that weren't previously here, or they are diseases that essentially are here, but we haven't quite controlled them. And so there are factors contributing to emerging diseases, and these factors are, we call this the epidemiological triad, where we look at the agent, the host, and the environmental factors. And so we have agent factors such as microbial adaptation, right? We have drug versus vector resistance. We have mutations, right? And these are usually drivers of mutation or pressures that drive mutation. We have host factors where we have things like population growth and migration, sexual behavior, risky sexual behaviors, or the use of antibiotics to remedy disease processes, right, that can lead to resistance, antimicrobial resistance. And of course, we have things like immunosuppression. And immunosuppression is very important because this is where you find a lot of your opportunistic diseases that will emerge, right? One of the emerging diseases that we have seen are, colonizing bacteria that are usually found in the anus. Women are now having bacterial vaginosis of anal colonizing disease because of the bisexual practices that are occurring in our current day practice, right? So that's just something that we should know about the host factors. And then of course we have environmental factors, which has to do with climate change and ecosystems in the ecosystems, the natural ecosystems, and migration. And because of migration, you may have species of certain organisms being found in parts of the world that they usually weren't. And of course, urbanization, deforestation, food processing, and handling are also key factors, right? Another thing that I want to share about climate change, or not climate change, sorry, environmental factors, is that because of the increase in international trade and international travel, regardless of COVID, right? We see where lots of diseases that are sometimes on the other hemisphere of the world can make its way to our hemisphere of the world and create a huge public health problem. So examples of emerging diseases, we have HIV infections, we have SARS, right? And we have SARS, and we know the SARS-CoV-2, which is a new version of that. We have the Lyme disease, we have the E. coli 057 and the H7, right? We have the hantavirus that causes their hantavirus pulmonary syndrome, which is really fatal. The West Nile virus that is usually found in Africa, right? But have been found in the Caribbean and in the United States. And of course, we have things like dengue fever and Zika virus, which were not originally endemic to the Caribbean or the Western Hemisphere, but because of this migration and mixing of populations, we actually have the transmission of these diseases. Now, with respect to a re-emerging disease, and as the term suggests, re-emerging, it means that it was here before, but now, something happened, we got it under control, but now it's happening again. So the definition essentially are diseases, emerging diseases are diseases that reappear after they have been on a significant decline. So that's a very simple definition. And reemergence may happen because of a breakdown in public health measures for diseases that were previously under control, right? And so, well, let me not use that example because I don't want to confuse anybody. They can also happen when new strains of known disease-causing organisms appear, right? And the human behavior affects reemergence. So for example, the overuse of antibiotics has led to disease-causing organisms that are resistant to medicines, right? We have some E. coli, that's where MRSA came from, your methicillin resistant, Staphylococcus aureus, and your vancomycin resistant, the VREs, Escherichia coli, and that sort of thing. It has also allowed a return of diseases that were once treatable and controllable to re-emerge, right? So again, factors that affect or contribute to re-emergence of disease are the same factors. I don't need to go through this again. The same agent, host, and environmental factors that affect the epidemiological triad, right? That causes these reemerging diseases to come forth. Now, reemerging disease includes malaria, right? Tuberculosis, cholera, pertussis, influenza, pneumococcal disease, which has gotten very popular in the last 2 years, right? And your gonorrhea, right? So your gonorrhea and TB were once under control, but we can see because of host factors, where host factors include your sexual behavior, right? These, your gonorrhea, for example, has also been increased. And as a result of even the inability to control the emergence of HIV, we see that TB, right, has been on the increase, and it's often found in patients who are immunocompromised. So it's not just HIV patients. We're not going to stick it to the HIV patients because that's unfair. Patients with cancer do get TB. Patients with severe forms of diabetes, they do get TB as well. We have our patients in our incarcerated population and in our enclosed medical services area. So we're talking about things like hospices, prolonged hospital stay, right? That sort of thing. These are also responsible for the re-emergence of TB. Cholera, we remember from 1852 when John Snow and the whole outbreak of cholera in the UK, and they identified by epidemiological methods the source of the contamination. We see because of a breakdown in public health practices and some environmental factors where cholera has definitely been on the rise. For those who would have remembered the earthquake, I think in 2009, January 12, 2009 in Haiti, right? Cholera re-emerged in Haiti. And truth be told, for those who would have read up on the story and the epidemiology behind it, the outbreak of cholera in Haiti was not as a result of the Haitians, but was as a result of a French aid worker, healthcare worker, health aid worker, who actually came with the contamination to Haiti, and that devastated the entire place, on top of having suffered a natural disaster. So the risk of re-emerging and emerging infectious diseases, we have international trade and travel, which I mentioned before, opportunistic pressure, which comes from your other diseases, as well as the environmental changes. Again, these factors, always keep them in mind, the epidemiological triad, when thinking of emerging and re-emerging diseases. Now, there are about 5 different types of microbes, right, that are responsible for, or pathogens that are responsible for causing conditions or causing issues, right? And so we have our bacteria, which we've already looked at somewhat. We have our viruses, we have our fungi, we have our protozoa or helminths, and in addition, a new class of infectious agents called prions has recently been recognized and acknowledged in the sense, well, not recently, but it's been a while, right? So the bacteria have no organized internal membranous structure such as a nuclei or mitochondria or lysosomes. Most bacteria produced by growing and divided into 2 cells, and this is usually called binary fission. For those of you who would remember a little of your cellular biology from CXC days, right? And so we have our bacteria. There are different types of bacteria based on their morphology. There are the 3 most common morphology is that you have a coccus, or cocci for plural, right? And it is literally a round ball, right? A circular organism. This is what they look like microscopically under the microscope. Then, of course, you have your rods or your bacillus, your bacilli for plural. And then you have your spirillum, right? Which your Treponema pallidum, for example, is one of these spirochetes or spiral sort of bacteria, right? And then there is the variant of the cocci infection, where you can have 2 cocci bacteria together. We call this a diplococcus. We can have a bunch of them looking like a bunch of grapes. This is called a staphylococcus. Or you can have a strip of cocci, which is called your streptococcus. So things like your Streptococcus Pneumoniae, right? This is because it is found in a strip when you look at it under the microscope. And your staphylo, like your Staphylococcus aureus, your Staphylococcus pyrogenes, right? Your staph infections usually look like a cluster of grape, right? And so some bacteria require oxygen, and so they're called aerobes, and you have some that do not tolerate oxygen well, and they're called anaerobes. And I know this is all basic for a lot of you guys, but it helps us to understand the genesis and where we're coming from with respect to our emergent and re-emergent disease. Now, some bacteria can grow either with or without oxygen, and these bacteria that are multifaceted, multi-talented, and are able to survive practically anywhere are called facultative anaerobes. Now, another way of identifying our bacteria is by their stains. And we use something called a gram stain. It's a very basic method of looking at the bacteria under the microscope and sees how well they have adapted or taken up the gram staining. So an organism that retains the stain is called a gram positive organism. One that does not retain the stain, right, is actually a gram negative. And the gram negative organisms, they appear pink after staining, and this is due to their very unique peptidoglycan arrangement, where we actually see that the organism has a cell wall, a peptidoglycan layer, and then it has a secondary cell wall that surrounds that peptidoglycan layer, while the gram-positive organisms usually have a very thick peptidoglycan or multi-layered peptidoglycan layer that absorbs the gram stain very easily, and so they have a purplish hue, right? So your GNBs or your gram-negative bacteria, we look at things like your Salmonella typhi, which causes your typhoid fever. You have your Yersinia pestis, which causes the plague, is transmitted by rats, right? And we have our gram-positives, which are that purple stain that we mentioned before, and your Staphylococcus aureus, which causes your skin and respiratory and wound infections, right? As well as your Clostridium tetani, right? Which is what produces that very lethal lockjaw. Let me just say that with your Staph aureus, right? Just a rule of thumb, an infection with a staph is actually the inflammatory response to a Staphylococcus aureus infection is usually less in terms of response time. And so this is one of the reasons why staph infections tend to be more virulent, right, than a streptococcal infection. So a streptococcal infection will cause symptoms, yes, but it usually responds very well to medical intervention, while a staph infection is usually a poor responder to medical intervention. And that's because you're more likely to have a sepsis from a staph infection than you are to have it from a strep infection, because of the poor immunological response that Staphylococcus itself inherently evokes in your immune system. Now, there are two organisms that I want to look at. Your Cyanobacterium diphtheria, which causes diphtheria, and it grows only on the nasal and the throat surfaces, and damage to the tissue can cause the production of enzymes or toxins, and this also can be distributed within, so similarly to your Staphylococcus aureus, because there's this poor response time to these organisms, they can spread quite easily through the circulatory system, and these are the things that can cause sepsis and cause cardiac issues and liver failure and issues within the CNS tissues, as well as multi-organ failure. Your Strep pyrogenes, however, is usually associated with your strep throat and your flesh-eating disease. This produces enzymes that break down the barriers between your epithelial cells and removes fibrin clots. And so this help bacteria to invade tissues quite well, right? And of course, your viruses are not organisms themselves. They cannot reproduce apart from the host cells. So they don't exist by themselves. While your bacteria may exist in an acellular, without a host for some time, your viruses do not survive well on without a host. And so even, for example, contaminated surfaces, each viral profile has a lead time or a time in which the organism is known to survive ex utero, which means ex vivo, which means outside of the body, right? And so on. So these cause disease by disrupting normal cell function as well. And they are classified using a variety of criteria, including their shape, their size, and the type of genome that they carry, right? So example of viruses, your herpes virus that cause chickenpox, cold sores, and genital herpes, right? Your HSV1, for example, is what is responsible for your cold sores, right? Or what we call here in Jamaica, night fever, for those persons who are not Jamaican. And for your HSV, your herpes simplex virus, or HSV2, is responsible for your genital herpes. Your varicella zoster virus is responsible for your chicken pox. Then you have your poxvirus, which causes the smallpox, your rhinovirus, which causes a common cold, and the coronavirus is also known to cause common colds. But we see that there was an emergence of a new variant, with a mutation that was more virulent and more contagious than the common coronavirus itself. And we see things like mixoviruses and paramyxoviruses that causes your influenza, your measles, and your mumps, and your rotavirus that cause your gastroenteritis, right? Rotavirus especially affects your children during the months of April to November, and so be on the lookout for that. We have Ebola on the rotavirus. These are known to cause viral infections where the babies usually, or the infants usually, develop a runny nose and a runny tummy, right? And so we have our retroviruses that causes AIDS and several types of cancers, right? And so here we have the fungi, which produce primarily by forming spores, and together with bacteria, fungi work to be the decomposers in our environment. And examples of these diseases caused by fungi, we see things like our ringworm and our histoplasmosis, right, which is a lung infection that is usually caused by bat and bird droppings. However, we know that histoplasmosis is an infection that usually generally does not affect the patient who is immunocompetent. And so persons who are immunocompromised, persons who do transplants, HIV, severe forms of cancer, that sort of thing, are at risk for developing these things. Yeasts of the Candida genus are opportunistic yeast infections that cause diseases such as your vaginal yeast infections. I mean, from you have a vagina, you can get a vaginal candidiasis, right? And the thrush, right? This thrush, however, is usually more commonly found in patients who are in the pediatric age population. However, when you start seeing these infections appearing in your patients who are of the adolescence to adulthood, then you are a little bit wary clinically, and you start suspecting that there may be some level of immunocompromise that is ongoing in this patient. There are, however, less dramatic versions of this, where the overuse of antibiotics, for example, right? Especially with your vaginal candidiasis. So some women will find that, for example, after a bacterial vaginosis and your physician prescribed, let's say, some Flagyl or metronidazole, you find that you get a little itchy after a little adherent white itchy discharge right after antibiotic use. That's okay, right? You're not HIV positive or dying from anything like that. You just have a normal response. And these things happen in women sometimes, especially women who are a little bit on the fluffy side, right? Diplomatically, the overweight, right? The obese, but persons who even do not wear, for example, the cotton-rich undergarments, right, are at risk of developing these things as well. Persons who who sweat a lot between the thighs. So if this is something that happens personally or to someone you know, you can just recommend to them that, hey, having cotton underwears will help dramatically in improving your vaginal health, as well as if you are someone who sweats a lot, then the use of some form of undergarment that has, some cotton, that breathable material, that will help with that tremendously, right? And of course, if you take antibiotics and you are prone to these things, when you're being treated for these little infections, I don't know, a sinus infection where you had an infected sinusitis and they gave you antibiotics. So you let your physician know this, that you're used to getting a yeast infection afterwards, and it'll be better. So for protozoa, right, they do have cell walls, right? So they are able to have rapid and flexible movements, and they can be acquired through contaminated food or water, or by a bite of an infected arthropod, such as a mosquito. So this is where your vector-borne illnesses are transmitted, right? But also your foodborne illnesses from contaminated water source that causes your infectious GE, right, can also occur, right? And so your Giardia lamblia, right, and your Cryptosporidium parvum are two protozoa parasites that cause diarrheal disease, very, very common in the US, right? And in the Caribbean as well, we also have that Giardia lamblia, right, in certain regions. Your malaria, which is a tropical illness, is caused by several species of the protozoum Plasmodium, flavum, right, and so on, and vivax, right, all those species, right, and they cause malaria. Your helminths are simple invertebrate animals, some of which are infectious parasites, and because they are animals, their physiology is similar to humans, making these parasites difficult to treat because drugs that kill helminths are frequently very toxic to humans. Now, with respect to your helminths, so like your worms, your benders, right, this is where we use our very famous bend drugs. So we have our albendazole, mebendazole. So anything that bends, we can use a bend to destroy its ability to move. And once you destroy its ability to move and to mate, you interrupt the life cycle of the organism and you are able to kill it. Right. Have these organisms, usually when they mate, they lay their eggs. And so it is quite possible that once you have infected or have an infestation with helminths, that you are able to transmit even contaminated fecal matter, right, within your surrounding, and that can lead to infections, right? Now, these helminths have very complex reproductive cycles and may require a host. So, for example, your schistosoma caused by a flatworm results in diarrhea and abdominal pain. Your Trichinella spiralis caused by a roundworm results in vomiting, diarrhea, and fever. Later symptoms include muscle pain, congestive heart failure, and your respiratory paralysis. And when it says that it has a very complex life form or life cycle, it means that, for example, your Necator americanus, which penetrates through the sole of the feet from children who walk barefooted, right? It causes little holes, right, in the feet, but then these organisms, they go to the bloodstream and they actually can cause an infestation in the liver. Even your Ascaris lumbricoides, right, which is an organism. I know this is not in the slide, but the Ascaris lumbricoides used to be very prevalent in Jamaica. And in Portland, for example, we know how many are here from Portland, but in Portland, there was an outbreak of asthmatic children in the 1980s, going into the early 1990s. And these children were wheezing down the place. And this is always the reason why you should never just take things at face value and always seek to investigate if something doesn't seem right. So there was a sudden outbreak of children who were not known to have asthma in the family, no previous history of wheezing or recurrent wheezing or anything of the sort, atopy, none of that. And we have an outbreak of wheezing. And what happened is that they found that some patients were coming with distended abdomen, and some were actually coming to the health centers and hospital with worms coming out of their bottoms. And so literally, they made a link. They were like, oh, when they pulled the worms out, there were these long roundworms, and the Ascaris is very, very, very distinct. And so a part of the life cycle of the Ascaris lumbricoides is that it migrates from the gastrointestinal tract to the lungs, where it is matured, and then the child coughs up the worms in their mouth and then it's swallowed back into the gastrointestinal tract. It's kind of gross. But when they have the pulmonary phase of this Ascaris lumbricoides, it actually was the reason why these patients were wheezing. And so when they did x-rays, they were able to find these little tiny radiopacities. And after deworming these patients, they were able to successfully treat some of these guys. And so I just want you guys to always bear this in mind, that when we see some very strange and wonderful things happening, that we should always be quick to investigate. So your prions, right, are linked to CNS degenerative disorders in humans and animals. And so usually these are highly linked to your CNS issues. And so this is where the very infamous mad cow disease, your bovine spongiform encephalopathy, right, occurs. And then, of course, you have your Creutzfeldt-Jakob disease in humans, and you have your scrapie in sheep, and some prion disease are inherent, and others are caused from eating infected tissue. And so even the mad cow disease being transmitted into the human sphere, this was done by the consumption of contaminated or infected tissue, meat, right, beef that was actually not properly prepared, right? So by way of extension, it means that epidemiological principles must be employed. So what is epidemiology? It is defined as the study of the occurrence of disease in population. And so if we're looking at emergent disease or re-emergent disease, we usually have to look at the epidemiology. So we have to orientate our data, we have to be oriented in terms of person, place, and time. And so from an epidemiological perspective, we're not only concerned with infectious diseases, but we also look at non-infectious diseases such as cancers and environmental diseases such as lead poisoning and other things of the sort. But some diseases like cancers that can lead to immunocompromise, this can actually give way or give rise to re-emergent disease like your tuberculosis, right? So this is where your health, you can't just look at it from a biological model, right? Where you're looking at just a disease, an agent, and the host, or the host, the agent, and the environment. But we also have to look at other factors that can influence that. And so again, our disease reservoirs, we mentioned it earlier, right? As we said before, there's a reservoir that for disease insights where the infectious agent can survive. And so in humans, in rodents, in soil, right? And the modes of transmissions of these diseases, whether emergent or re-emergent, can be direct or indirect. And so your direct contact, and especially in this setting or forum where we're looking at infection prevention, right? Your direct contact is when an individual is infected by contact with a reservoir, with a disease reservoir, right? And this is, for example, touching an infected person, it's in infected foods, being bitten by an animal that's infected, inhaling infectious particles or droplets from sneezing or coughs, or intimate sexual contact. And some of these examples include your ringworm, right? Your Tinea corporis, right? Your Tinea capitis, right? We have things also like scabies, for example, that is a very common condition, right? That happens as a result of direct contact. Your HIV/AIDS, right? Your trichinosis, your influenza, your rabies, and your malaria. And then, of course, your indirect contact occurs when a pathogen can withstand the environment outside its host for a long period of time before infecting another individual. And these examples, we have things like your fomites, which are your door handles, tissues, or solutions from sick people ingesting food or beverages contaminated by contact with a disease reservoir. Whatever the case may be, the mode of transmission is not deemed as direct. And so one of these very prominent is the fecal-oral route, right? And so your cholera, which cause your GI infections, your rotavirus, your infections, your cryptosporidiosis, and your giardiasis, right, are examples of these. And your AIDS, your HIV, right? Your HIV and your herpetic encephalitis can also be transmitted from parent to child, and that is an indirect route, right? So the role of research in prevention. So the reason why we're looking at all of this is because we have to look at the data, and we have to use the data to orient ourselves in person, place, and time. When you use the John Snow approach in 1852, which was a very commendable action by Mr. Snow, by the way, where there were a lot of persons dying from cholera during that outbreak. And when he decided that he wanted to know why these people were dying, everyone was having vomiting, diarrhea, rice water diarrhea, profuse diarrhea, and they were all living in a particular geographical space. Now, at the time, this was an emerging condition. And so based on investigation, he counted the number of deaths as opposed to the number of sick persons. And when he actually got his data together, he recognized that majority of the persons who would have gotten ill were persons who were actually drinking water from a particular pump. Back in those days, you received water through pumps. And so there was a pump on Broad Street, the Broad Street pump, very infamous Broad Street pump, that was the source of the contaminated water source. How it got contaminated, no one knows. But because they were able to identify that majority of the patients, or almost all the patients who got sick, were taking water from that pump, what they did were they identified the pump, they condemned the pump, and literally the numbers plummeted. Likewise, in the COVID-19 outbreak, remember where we identified the source of the outbreak. It was in a meat market in Wuhan, China, right, where persons apparently were actually selling contaminated bat meat, right? And so that is the story that we're going to go with, and we're going to stick with it, right? So the role of research and prevention is understanding the infectious cycle is critical in order to identify accessible targets for control strategies. So just like John Snow, he identified that, hey, people were drinking water from a pump, and this pump was located on Broad Street because that's where the majority of the patients were. And we need to condemn this pump. And so they condemned the pump, which is a public health act. And it actually had a significant impact on reducing the burden of cholera, right? So vector-borne diseases may be prevented by control methods that either kill the vector or prevent its contact with humans. So they weren't killing the Vibrio cholerae, but they were able to prevent the humans or the persons who lived in that area to come in contact with it. Now, vaccines may prevent the development of a pathogen within a host, and drugs may be used to prevent infections or suppress the disease process so you don't transmit it to other organisms or other persons. But of course, the host defenses against the infectious disease. We also have our own internal mechanisms of prevention and amelioration of these, or mitigation of spread. And these include your anatomical barriers, such as the skin, the bone, the nasal passage, which are lined with hair cells. And they help to trap debris as we breathe them in. Your physiological deterrents to pathogens, such as your tears, your sweat, your blood, your vaginal secretions, and the presence of your normal flora within the body. So we're looking at the colon, the vagina itself, anus, that sort of thing, even the mouth, right? And the skin, right? So the normal colon. So immunity, right? We can look at this in a very generalized sense. Once you have invasion, your body responds by having an immune response, which can be varied. It can be very quick, or it can actually be delayed depending on the pathogen. But vaccines are another way in which we can actually help to protect ourselves. And a vaccine is either a kill or weakened strain of a particular pathogen, and the body's immune system will respond to these vaccines as if they contain the actual pathogen itself. Now, as a result, memory within your lymphocytes. So we know about the T lymphocytes and the B lymphocytes and the plasma cells versus the memory cells, right, in our basic immunology. But as a result, the memory lymphocytes will rapidly respond when the actual pathogen is encountered, destroying the pathogen before it can reproduce, and actually causing sensing of that to create memory cells within your body from the B lymphocyte perspective. Right, so some pathogens have a way of evading the immune response, either by allowing antibodies to pass through their cells, or by disguising themselves as a host cell, or literally by mutating. And sometimes they actually fuse to the host cell to avoid detection. Right, the colon and influenza virus are examples of rapidly mutating pathogens. And so it's almost difficult to actually create a vaccine that will prevent all flu virus or all cold viruses. Right, and that's because you have things that are called genomic shift and antigenic shifts that occur because they can shift and mutate so easily. Right, so winding down, of course, utilizing broader public health measures such as safe water, travel. I wouldn't say restrictions, but travel cautionaries, right, or precautions, right. When you're traveling to countries that are endemic for some diseases, right? These are things that you want to take into consideration. And you want to actually look at, just some of the public health practices of water purification methods and things like that, especially during times of or hurricane season, for example. Even these practices can actually determine whether or not a huge gastrointestinal outbreak can actually occur during those seasons, right? Now, food safety programs, of course, we're not going to go into this too much, but we see, for example, with the prions, with the mad cow disease, which was an emerging disease back in the 1990s, coming into the 2000s, right, when we had that huge mad cow scare where people stopped eating corned beef and beef altogether because there was this brain-eating disease that had people going crazy, right? But of course, with all the ISO restrictions and preventative processes that are applied to food safety, right, this has somewhat been mitigated, right? In terms of animal control programs as well, which is very important here in Jamaica, right? We have to ensure that foods consumed are foods that are actually passed by our public health partners. And so we want to ensure that, we're not buying illegal meats, because sometimes there are animals who actually die from natural disease. I've seen on a tour with the environmental health team from the KSA Health Department, I've had the opportunity of seeing diseased meat, like diseased cows and goats that had things like lymphoma, the animal version of lymphoma, and even some contagious and infectious diseases that they died from. You could see the pus within the meat itself, that some vendors actually, they have a way of washing it out and masking these things. And so if you're purchasing meat from, unvalidated source, then you should be very careful because you put yourself at risk, right? So vaccination programs, we see where most in all states or countries, you have to have a mandatory vaccination protocol for, I'm not talking about COVID now, guys, mandatory vaccination protocol for diseases that are considered life-threatening. So of course, your measles, mumps, and rubella, your polio, that sort of thing. There are about 13 mandatory vaccination, that these vaccines are designed to prevent disease. I'm not talking about seasonal vaccination protocols, I'm talking about diseases that are preventable by the WHO PAHO standards, right? And we utilize them especially in areas to prevent contamination. Right now, city and state agencies are responsible to enforce these regulations. And so in the context of emergent and re-emerging disease, right, we do have an active surveillance system, right, that exists. So we have seen a lot of this functional, or the systematic function of this program actually came to the fore in COVID, where people were able to see statistics, numbers, the total number to date, year-to-date figures, how many persons tested positive today, how many persons died, right? We saw a demonstration of this organization of our health services through the public health system. But we do actually have a surveillance system that monitors, right, the appearance or emergence of these conditions, and also the trend in which they are going. So we know that during this season, right, the rotaviruses is supposed to go up. You may see an increase in your influenza type viruses and that sort of thing. And we know this because we have a database that we can look at. In the United States, they have the NIH, they have the CDC, the FDA, but in other parts of the world, we have the WHO, we have the Ministry of Health here in Jamaica, we have PAHO, which is responsible for the Caribbean, Pan American Health Organization, which is responsible for the Caribbean and Latin American territories. We have our Ministry of Health, we have our regional health departments, SEROS, Southern Regional, Northeast Regional, Western Regional, and we have our local health departments, which we can always get our data from. And of course, the secondary care surveillance systems, which is usually headed under the infection disease prevention and control units that are located in the hospitals, right? So the treatment of these emergent or re-emerging disease, right? Usually, the antibiotic literally means the destroyer of life. So they usually require the use of anti-agent, antibiotics, antivirals, right? But antibiotics, it's a substance, a chemical substance used to treat these bacterial infections. By the way, just want to say that even your antimicrobial agents are sometimes the reason why some of our diseases are re-emerging, or we're having emergence of some diseases, like your multi-drug resistant organisms, like your VREs and that sort of thing, right? So your TB cases where you do have drugs that are, you have organisms, TB organisms are already having resistance to rifampicin, right? And of course, you have things like your sulfonamide, which interferes with the synthesis of folic acids, and which is a necessary for nucleic acid synthesis. And so some organisms will actually find a workaround by actually producing their own folic acids, right? So a lot of these things, even HIV patients, because of the frequent use of your atazanavir, right? There is that probability that it actually the organism itself develops resistance to the drug, and it actually aids in the replication of the HIV genome. And so a lot of times you find that there is a change in even the drugs that are used as recommended therapy for some of these conditions, right? We don't have to go into this, but I think I'm gonna end it here. It has been an hour, and I just want to say thank you for your time. Let's get this back over here. And let me just stop sharing. And yeah.
All right. Thank you so very much, Dr. Jermaine White. A wealth of information there, looking at emerging diseases from the environment, agent, host, a number of forms, bacilli, cocci, and all of this wealth of information. What we need to look out for, the food sources, the water sources, and the fact that there are surveillance systems in place where we can collect all of this data. Trust me, rich information. We appreciate you, and we thank you for availing yourself to come on again to be a part of the Omega Kappa Infection Control series. I just want to say thank you to all of you who have joined us and stayed. Of course, the information was rich, and I would like to take your questions at this time. I don't know if there are questions over on YouTube. We can check there. I think the information was very much clear. So I think persons had an opportunity to digest and fully understand. But if you have your questions, we will accommodate them at this time. You can raise your hands or type them in the chat. Don't be shy. We will facilitate your questions. Going once, going twice. Dr. White, I think your presentation was so awesome and so clear.
I have a question, Madam Moderator.
Thank you.
If I may, thank you.
Oh, and there, Mrs. Saranash has a question as well.
All right, so Dr.
Right
White
ahead.
alluded to the antibiotics that may also be a cause of the re-emerging. I just wanted to know if you could give us a few more sentences to expound on that.
Oh, thank you so much, Cheryl, for that question. Yes, because of the, I would say, prejudicious use of antibiotics, we have seen in a lot in medicine in these last years, where people are being given prophylactic bacterial or antibiotic therapy for viral infections. And that has actually contributed to a lot of multi-drug resistant organisms occurring in our day and age, right? Antibiotics should only be prescribed in cases where there is a proven bacterial infection. Now, remember, even though antibiotic means destroyer of life, right, it's not used for virus. So if you're just having the common cold, it will be unwise and very imprudent to demand antibiotics from your healthcare provider. And best believe, because of cultural practices and misuse, we have had several patients who are just having a common cold and want some antibiotics because they're told just in case they develop and it's just wrong. So we have seen that even or some of our strep pneumonia infections are now resistant to certain drugs, right? Which is an infection that causes the common pneumonia or bronchopneumonia, right? So.
All right, thank you, Dr. White. Just a quick part B before Mrs. Sernash.
Sure.
Can some of this be attributed to the fact that a lot of Jamaicans have a habit of feeling better and not taking the complete dosage of the antibiotic that was prescribed?
We actually dealt with that last year, and yes, you are completely correct. So I see that you were paying attention to the lecture last year or the talk last year. And so incomplete therapy definitely is a part of it. We do know that most antibiotics are prescribed for a period of 5 days on average to 7 days. But by day 3, you're usually feeling better. And so a lot of us, because we feel better, we tend to halt the medication use. And that can lead to mutation and drug resistance as well. So excellent observation.
Thank you for your response, Dr. White. I found it interesting, the translation, and thank you for that question, Mrs. Garrix-Lloyd, that the antibiotics literal translation is that the killer of life. Another thing that persons tend not to pay attention to is that it's not just targeting those invading microbes, it's also killing off the microbiome, your good gut flora that is keeping your immunity up and so on. So there are implications, not just on one end, but for your internal system as well. So thank you very much for sharing that. Mrs. Sernash.
Even with respect to that very same point that you just made,
yes.
With respect to the balance, because in the vaginal flora, there is a balance of your good bacteria, your lactobacilli and all those things, along with the Candidal species. So it's there. So when you take antibiotics, even after prescribed use or just for having no need imprudently, then you decrease that flora, that good flora as you mentioned, and then you have the Candidal infection that emerges, right? Or
because of the opportunistic nature, yes.
So excellent.
Thank you for that, Dr. White. Mrs. Sernash, it's your turn.
Yes, thank you. Thank you, Dr. White. Just wanted to add my 2 cents about some studies that I read a little while ago that spoke about patient satisfaction, especially among the pediatric population, where the parents did not score the physicians very highly or their visit very highly where satisfaction is concerned, unless they left with some antibiotics, even though the child was not in need. So, as we move forward to looking at how our patients are feeling satisfied after a visit with us, we want to ensure that we balance good medicine, good nursing with the patient satisfaction. We can be prescribing antibiotics only because we want a good patient satisfaction score. So that's just my little 2 cents. And just to say, thank you so much, Dr. White. Some little connections that were fading over the years. You did an excellent job in reconnecting those dots. Even some of the names, I got refreshed as to, where these names came from and so it was a really good presentation. You went from simple to complex and I followed along every single step. Good job. Thank you.
Thank you, Mrs. Sernash.
Thank you for sharing, Mrs. Sernash. Absolutely. I think too, you'd probably be taking a whole new look at walking up and down outside for fear of those Ascaris.
Oh, trust me, that is one thing I insisted on. My child never walked outside barefooted.
I have a challenge with that one.
Just show them the worms. Show them the worms.
All right, I saw Vivette, I think it was, with her hand up. We can still accommodate your question if it wasn't by error. But in the meantime, while we're having persons think about their questions, we will read some of the comments. Maureen Young Soil says, excellent presentation. content was clear, easy to understand, and she expressed her thank you. Jennifer Sands says, thank you, Dr. White, for a clear and easy to follow presentation. Moya Harris Hamilton, excellent presentation, very clear, on point. And Saunders, Andrea Saunders says, excellent presentation, Dr. White, very clear. So I see they concur. Was very easy to follow, very easy to understand. And we have chiming in from YouTube, Sonia Wallace. She said, very interesting information. We just see an outpour of appreciation there for the wealth of knowledge that you shared. We'll give another opportunity for persons to have any points that they would like to clarify. If not, at this time, I will hand over to our President, Vibrant President. I love the work you are doing. Let me just extend my congratulations to you and to commend you on your continued hard work with the Omega Kappa chapter. Over to you, President Cheryl Garrett-Sloyd.
Thank you so much, Madam Moderator Camille. Thank you, Dr. White. You know, we have the opportunity to have persons join us as honorary members, you know, Dr. White. So we have to kind of induct you, put you in, squeeze in a little. We appreciate all that you do and always for being on board. And I agree with everybody today. You have a way of sharing that makes it easy to follow along. Even when I lost in some of the things, I looked up at one point when you said, and the grape-like cluster, which is the staphylo and the chain, and then I'm like, Jism. So I think you're doing an awesome job and we want to thank you. I want to thank everybody who joined us. So just a few quick things before I share with you and we close off. So we are going to be finished early today, but each session is 2.5 hours. So don't worry, today will still be that you'll be awarded your 2.5 CE hours, but just a little bit of info as we close out. So to make sure you are all paying attention, first thing, Camille Bell Duncan, is that it? Camille said she got 8 words. And I told Camille, please send me the picture evidence. Camille, I haven't received it yet. There's still time while I'm talking, right? And then just a little bit of reminder for all of you who joined us today, either on YouTube or here in Zoom land, we thank you so much. Please pass the message along. 1, we are a nursing chapter of very busy individuals who are nurses or nursing students or studying and are working. It cannot be that we expect the registration to be open and a response to be available to us if we're trying to register an hour before the session starts. There are lots of things that happen in the background to prepare for us to have an excellent webinar series with you. 2, we have 2 people, maybe 3, who have waited in the waiting room and eventually given up. We are allotting your CE hours. We will have to prepare your certificates. That is why we insist that you join us with your full names as you registered, because that is who will get the CE hours. We can't give it to iPhones and Samsungs and Jussie B or B Brown or T Smith. It doesn't work like that. I'm encouraging everybody to just be on board, do a little practicing, and to ensure that you are able to rename. So just in case you didn't know, we had 2 of these sessions last year when we did this series. We looked at Zoom in particular, but online platforms. So right where your name is, when you come into the Zoom session, you should look over to the right of it and you should see a button that comes up when you hover and it will say more. Sometimes it may not be the same from your phone as from your laptop. But when you see that more button and click on it, it should give you an option to rename. And then you should be able to type in your name. So we're just encouraging everybody, tell somebody, if you're joining us for the rest of the sessions, please ensure you're joining us on Zoom with your full name as you registered to be let into the session. When you come into Zoom land, you don't need to write your name in the chat because you were already let in with your full name. And for all of those who have joined us on YouTube, thank you again. Type your full name in the chat over there so we can say, oh, we have this person joining us over on YouTube. Thank you for subscribing to our channel as well. All the information we've shared from last year is there, and the things we are going to be doing will also continue to be shared over there on our channel. So, Camille, waiting on the WhatsApp message to come. 1, 2. I have 3 questions to see if everybody was paying attention. And let me just put out the disclaimer. The moderator cannot answer. All right.
Mrs. Garrick Lloyd, let me just share. Mrs. Camille, what's her name? Camille
Bell Duncan.
Bell Duncan. Did you
Yes.
not see her pop up her words?
No,
ready?
it popped up
shared.
really. It popped up really quick and went away.
So-
but I tell her
so
send it to me.
Yeah, so tell her the appropriate. I'm thinking that probably she would like.
Yes, I typed my number in the
avenue
chat to her.
All right, so
Yes, so I'm looking out for
Camille, go over there, look in the chat, and you have to send Mrs. Garrick Lloyd a WhatsApp
Yes, please.
message.
She was the only one who said
right?
8, right?
Absolutely.
So congrats to her if she got all 8 very right. Just in
Alright.
case, I will double check who were the 7 people, but everybody ready now? We're looking to see the chat blazing up before I finish off with my very small presentation, you know. I have 3 questions and I need the answer for all 3 one time. Don't bother type them one because if I have a little prize, I'm going to have to scroll up and down to see who gave the 3 different answers. So listen up. Over on YouTube, right here in Zoom, type the answers all at the same time for me if you can. First one, Dr. White said we have a new class of bacteria that was recently named. What is the name of the new class? Right? I'm not giving any clues yet. What is the name of the new class of bacteria that Dr. White spoke about? Question 2. He gave us the bacteria and he said that if you look at how it looks, you're able to have an idea of what's the word just went right out of my head. That's the name that comes before, right? So he said we had some different looking ones and I alluded to it earlier. What's the one that's the string looking like bacteria? Give me the name for that one. And then the last question, we had quite a bit of uproar when mad cow disease came here. I don't know if anybody was looking at this slide, but what's the correct name for the mad cow disease? Ready for the 3 questions again? Because I expect to see lots of pinging. First one, what's the name of the new class of bacteria that Dr. White told us about? Give me the name for the one that looks like a row of string, a bead of strings. And then the 3, if you saw it, what's the correct name for the mad cow disease? I don't see anybody typing. Dr. White, you don't have a little prize there. So please type in the chat to everybody and let us see, type all your answers at the same time. We're giving you 2 minutes. Jism, we have a bright sparks in here near Maureen Young Swill. Dr. White, that looks like it's right.
Affirmative.
It looks right.
Yes.
All right. Boy, Mrs. Young, so they can type fast, man. Thank you to those over on our YouTube channel. I saw some people typing.
I've written my notes, you know. I have notes
Giza,
right
oh,
here.
you
Yeah.
go student. She was taking notes. So we're going to have to work on the prize for you. So just in case you didn't get it, the new class of bacteria are the Prions and the chain-like looking bacteria. That would be the Streptococcus. So the Strepto, based on how it looks, that's what the chain-like look is, right, Dr. White? What was the description? The grapes was the Staphylococcus.
So the Strepto, just remember the Strepto looks like a strip, right?
Strip.
The name.
Thank you, sir.
So
it looks like a strip, and so it's a Strepto, and then you just put it onto the coccus. Perfect. And then mad cow disease is correctly known as bovine spongiform encephalopathy. All right. Thank you very much, Madam Maureen. Thank you that you were all writing your notes and paying attention. Awesome job. All right. So just before we close out, as we did last year, we have a little bit of information to tell you about Omega Kappa, because you may have seen the webinar, Who Are We? It's a chapter of nurses. And I will share a little bit about what we have done in our 2 years of existence, and then close off with just one small bit of information for anybody who is interested in hearing more and or in joining us. All right, so please let me know, are you seeing my slide? Anybody seeing my slide?
Yes, we are.
Wonderful. So for this part of it, you just need to listen for a few minutes and then we will be able to close off. Hello, everyone. My name is Cheryl, and I have the distinct honor and privilege of being the current president of the Omega Kappa chapter of Sigma. Geographically, we are located at the UE School of Nursing Moon in Kingston, Jamaica, but we are a multinational chapter with members here in Jamaica, in Trinidad and Tobago, the Bahamas, the United States, and in England. Let's talk about our 2019-2021 biennium. It was filled with ups and downs, and though we were a little disappointed, we were also grateful for many things. We do miss our face-to-face interactions. We miss each other as well. And despite that, we continue to give of our best. We continue to maintain the protocols and we continue to support our members and colleagues, especially those on the front line. Let's have a quick look at our biennium to date. We had a few activities we had to cancel or postpone, some planned, some are annual activities, and we even had to cancel our first year anniversary celebrations. However, we did start our biennium as a 1-month-old chapter conducting our health fair or annual International Coastal Cleanup activity or mental health day activity, and we were able to attend our first Sigma Biennial Convention in Washington. And we had our membership participating individually in various outreach and educational activities. Let's have a quick look. And as COVID came to our shores in 2020, we are grateful we were able to complete the following activities. We had our first radio and television interview, our first Zoom chapter check-in, just to see how we were doing as membership. We were able to use e-cards and videos to celebrate all our major days in nursing and midwifery, our anniversary, and to close out the year for Christmas. Planned our first virtual webinar, commenced an article series about nurses in a local newspaper. We were a part of the Post Leadership Connection CEO live chat, had our first virtual induction to close out the year, and had our members participating in various activities and attending Sigma webinars. Let's have a look again.
It's International Year of the Nurse and Midwife, and with the COVID-19 pandemic, they've been under unusual pressure across the world. But nurses are more than just their uniforms. And joining us now to tell us about the work of the Caribbean Honor Society of Nursing is Cheryl Garrix-Lloyd, lecturer and president of the Omega Kappa chapter of Sigma at the
And in 2021, we've continued with sharing up the Sigma resources with our membership or other colleagues and the nursing students. We're participating in outreach and educational activities as individual members. As a chapter, we are also actively participating in our regional activities in COVID-19 education and vaccine campaigns. And we've been accepted for presentations at the biennial convention coming up in Indianapolis. We were able to submit 2 members for the International Awards for Nursing Excellence, and we've been collaborating with other chapters. Another quick look. And so as we close out the biennium, we continue to work on engaging our members to increase our social media presence, to continue to have publications and continue with our series, to have other educational webinars, to have a chapter and membership celebration event. We continue to infuse joy and we continue with outreach and educational activities. As I close out, I want to say, I'd like to express my gratitude to our members for all their contributions as a chapter and individually to nursing, healthcare, and Sigma. We thank our families, colleagues, and partners for their support. And we want to thank our hardworking regional coordinator and Sigma for all the support that we've received. I would personally like to thank my current board, my past board, my exec, my immediate past president. Did we just lose the sound? Is everybody hearing?
For their support
Okay.
and hard work in ensuring that we were able to meet our Sigma obligations and deadlines on time. We continue to work towards being connected, empowered nurse leaders, transforming global healthcare as we remain committed to developing nurse leaders anywhere to improve healthcare everywhere. Let's continue to infuse joy. We are
All right. So thank you so much for just listening. And I just want to say one thing, that we are the Omega Kappa chapter. And while we did not get a say in the naming of our chapter, all the chapters of Sigma Theta Tau International Honor Society of Nursing are Greek, and we got Omega Kappa. And then we were like, oh, but then we decided it's wonderful because we just call ourselves okay. So just in case you want to hear a little bit about more about being okay, and if you want to be okay, then we're inviting you to join us next week, Tuesday, 5:45 p.m. Jamaica time. We're going to be sending this flyer out as well. Share and tell everybody. And that will be 1 hour of us sharing with you, taking all your questions and answers, and having you understand who we are, what we do, what are our plans to impact, to continue to impact nurses, nursing, and healthcare. How do we become empowered? How do we find ourselves at the table? How can we do individual and chapter activities that will make a difference in our profession? So we're looking out, and we're hoping that we will see you next week, Tuesday. So that's separate and apart from the series, because some people joining us tomorrow and Thursday. I hope you got the emails with the topic so you can remember which one it was. And then there is next week, Monday, and there is next week, Thursday, Wednesday and Thursday, when you'll be looking at the 2 non-nursing sessions. So squeeze us in on Tuesday to hear a little bit about the chapter. And we want to really extend a big thank you to, this is our series number 3. We had this last year because Nursing Council did say we need 10 infection control. And we said, well, you could just do the non-nursing at the same time. By popular demand, we had a number 2, and here we are with number 3, and we're off to a roaring start. So as I close out, I want to say thank you to all of you for joining. Thank you to Dr. White for starting us off, and thank you to Madam Camille for her excellent moderating. We are okay, and we hope to see you going into this week and the next week, and to have you join us as a chapter. Have a very wonderful rest of your evening, everybody. Madam Camille, we'll be in touch. And congrats, Madam Maureen, we should be in touch as well. See you tomorrow and or whenever you're joining us again.
Okay, Sharon, thanks.
Thank you. Bye.
Bye.
Bye, everyone.